Research is the cornerstone of innovation in clinical practice, driving improvements in patient outcomes and shaping the future of medicine. Welcome to the Global Rhinology Network Topical Research Symposium. I'm Ashok Rokade from Winchester, UK, and it is my privilege to welcome you as a host. Joining me as co-hosts are Louise Melia from Bath, UK, and Professor Thibault Van Zele from Ghent, Belgium. This symposium showcases fascinating topics across 4 key modules: General Rhinology, COVID session, and Research in Chronic Rhinosinusitis. A special highlight is the PhD session featuring research conducted by enthusiastic young rhinologists who represent the future of our field. This symposium brings together leading global minds in rhinology who will highlight latest developments with a focus on translating research into impactful patient care. The Global Rhinology Network is dedicated to advancing knowledge innovation. Thank you for being part of this exciting journey. Thanks to Medtronic and Christos for their generous support in making this symposium possible. Welcome to GRN-Topical Research Symposium.
I'm delighted to invite one of our founding scientific committee member, Professor Christos Georgalas. Christos is a professor of ENT in Nicosia in Cyprus, and he practices in Hagia Hospital in Athens in Greece. He has been trained in London, Amsterdam for his rhinology fellowship, and then moved over to Athens for his practice. He has contributed to many book chapters. He has written his famous book in rhinology and the frontal sinus surgery with Professor Anshul Sama. He runs various international courses. So over to you, Christos, and it's more clinically relevant topic about frontal sinus surgery.
Thanks very much for the very kind introduction. We know each other for many years, and it's an honor and a pleasure. And actually, I was listening very carefully to the previous talks. It was very interesting discussions about biologics, which I must say it is the current the hottest issue right now in rhinology probably. But I will change the subject, as they say. I will change the issue, and I will give a much more, let's say, more. It is not less most practical, but more surgical talk. Let's talk it like this. So I'm talking about. I will keep my 10 minutes, and be talking about the lateral limits of endoscopic approach to the frontal sinuses, which basically for us, for surgeons, it's always the issue of how far can you go laterally when you are working in the frontal sinus. And always the issue is, when do you tell to the patient, sorry, I cannot do it endoscopically, I have to do an external approach. And there's nothing wrong with that. What is wrong is to be lost along the way, to start endoscopically and then have to change your mind. So apropos of surgery for osteomas, and we did a sort of a systematic review. It's more than 10 years. Looking back, it's 2011, so it's 11 years ago. And what we looked at the different indications at the time for surgeons to do an open approach, an external approach to osteomas. And we found all of these different limitations. You can see the studies from SIG and CIU and Bignami and Castelnuovo's group. And it seemed that lateral to the orbit, 2 centimeters lateral to the orbit, lateral to lamina papyracea were clear contraindications, attachment superiorly, posterior to the frontal plate. All of these in different authors, in different papers, were contraindications. And then going further forward, very recently, 2019, there was also an attempt at classification, systematic review. And when what's grade osteomas, like grade Cs, cannot be dealt with endoscopically. So let's look at some of these contraindications and let's see how they stand today. So lateral extension. Propos of this case, 39-year-old male, left frontal headache, and this is the osteoma that you can see is extending in the frontal sinus. It's certainly extending laterally to lamina papyracea. It's more likely about 2 centimeters lateral to the medial wall of the orbit. Is it approachable endoscopically? Would one need to do an osteoclastic flap? What are the criteria? Well, certainly goes laterally to lamina papyracea. However, what is interesting is that the size of the frontal sinus itself is not very wide, while the side here, as you can see from the septum to the orbit, is relatively big. And that, in my mind, meant that I can use this kind of approach to reach it without too much trouble via draft 3. And indeed, when we went surgically, we're starting the draft 3. I'm not going to go through the whole operation, raising the flap. I always try to raise the flap, finding the first fibers, and then starting the drilling. The first, not all fibers, the first branch of the anterior ethmoid artery and nerve. And there you can see the drilling in the midline and drilling and attacking the osteoma medially at first, and then trying to debulk it, take the bulk of the osteoma out, going more laterally and more laterally. And finally, the last parts, the part that goes over the orbit, can be removed. And you can see as it's coming nicely. You can see you have taken it out completely when you see that you remove it. And that's the posterior limit as well. And at the end of surgery, drilling the most lateral superior part exactly at the limit. And this could go out. So in my mind, that made me think that maybe, and then attaching the flap, of course, and then the post-op view, and the pre and post-op. And that made me think, you can see it here, that is a complete removal of the osteoma with no evidence of any remnant. What about giant osteomas? If it's complete obstruction of frontal recess, complete pacification of frontal sinus, broader completely filling, again, this kind of osteoma, I think could be considered as giant. It's more than 3 centimeters, actually it's 4, completely filling the frontal sinus, and definitely very similar way it can be completely removed. I'm not going to go into all the video because the point is not to show the videos and how it's removed. The point is to try to make some logic from this. And the final parts, and the anterior skull base is drilled out, and the nice empty cavity. So pre-op and post-op. So contraindications, we talked about intracranial extension, we talked about the lateral extension, and how does lateral extension is measured? How far laterally can you say that you can access? So what I thought is that it doesn't have to do so much with the anteroposterior diameter. People used to talk about the anteroposterior diameter. I think it's about the lateral diameter, and specifically the lateral diameter of frontal sinus compared with the interorbital distance. So this is the anteroposterior diameter, which I don't think in most of the cases is the real issue regarding the action of the frontal sinus. And this is the 2 measurements that we took. So from the midline, we looked at the most lateral axis, the most lateral distance in the frontal sinus, and from the midline, the distance to the medial wall of the orbit. And our theory is that the smaller is the ratio, in other words, the bigger is the rate of the mid-orbital distance to the lateral distance, the easier is to access the frontal sinus. And we looked at different measurements. We looked at anteroposterior distance at some heads, and we scanned to measure the distances. And we found that this is the ratio, the mean ratio that we found for the mean distance lateral to medially. And all of these measurements were correlated, and that makes sense because the more aerated is the frontal sinus, then the most likely that the ratios will be wider, both in the anteroposterior and lateral dimension. However, what we try to look at is whether a 70-degree instrument, such as a 70-degree drill, could reach the posterior or the lateral wall of the frontal sinus. And we measured the different heads, and we tried, after a complete geometry, to access these regions. And what we found is the specimens, the heads where the ratio was smaller, and actually it was a mean of 2.1, we had much better access, much more chance of having a lateral access than the heads with a bigger ratio. In other words, where the lateral frontal sinus was wider, much wider than the interorbital distance. And this was important also for superior and for posterior wall access. And more importantly, as we found in the statistical analysis, only this ratio was consistently predictive of access to these walls. And visualization of 100% laterally was achieved with a 30 and 45-degree endoscopes, while every lateral recess could be reached with a 70-degree suction. And this was the most statistically significant measurement from all of the measurements that we did in the heads. And that's, of course, in addition to the orbital suspension, which, as you know, is a technique that can also reach more lateral to the frontal sinus. So what we did finally, we looked at, I'm not going to go into the details about the anterior table, that's another issue. We looked at, this is an osteoma that goes very lateral, very anteriorly. But what we looked at the patients operated, total of 36 patients with osteomas of the ethmoid and frontal sinuses. And what we found is that from 2007-2015, there was a combination of external endoscopic approaches. But from 2015-2022, total of 17 osteomas were removed endoscopically, and consistently the ratio was in the osteomas removed endoscopically was smaller than the osteomas where one had to go externally. So to conclude and keep to my 10 minutes, the endoscopic approach may be helpful for the osteomas, especially when you have a very thin anterior table and avoiding reconstruction. It's very well tolerated. Instrumentation is vitally. The texture is important, but more importantly, to think if you can access the osteoma laterally, you have to look at the ratio of the lateral frontal limb to the medial orbital wall. And of course, must always be ready to change to an open approach osteoplastic, while there is certainly no need anymore for a Lynch-Howard or Gruden decision. And the team that we worked with, and thank you very much. And I kept to the 10 minutes, I think, exactly. So there will not be any delay from apropos of me.
Thank you, Christos. That was really wonderful, helpful for surgeons who deal with the frontal sinus regularly. The question I have, I mean, this was all, the talk was osteoma focus. There's no reason it should not be applied to the other pathologies. So what other pathologies you deal with going the lateral most, approaching the lateral most?
Lateral mucocele is a good example. We see very often cases where you had either nasal polyposis, or yesterday, actually, we had inverted papilloma that has obstructed the frontal recess, and as a result, had the mucocele laterally, supraorbitally and laterally. And also we had cases of a very quite lateral dermoid cyst that we had to remove in that way, as well as CSF leaks that go laterally in the frontal sinus. Inverted papillomas, I think these are all pathologies. We're actually now doing an analysis of the cases involving the lateral part of the frontal sinus and how far could we reach and what is predicted in real case scenario. I think that's more interesting than the case study.
So you won't necessarily have a higher, lower threshold to convert it to open approach in pathologies like inverted papilloma.
But it happens less and less, honestly. It does happen less. I think that we use the 70-degree endoscope quite a lot. I find it helpful. It takes some time to get used to the 70-degree endoscope, but it is a very powerful instrument once you get the hang of it. And of course, the 70-degree drills and the instruments, the Castelnuovo forceps is very useful. The double curved, forceps from the Storch. Yes. What's your experience, Thibault and Ashok?
Yeah, Christos, we started doing some osteomas and lateral-based mucoseals combined with a draft type 2B, combined with a superior eyelet incision. And that's also very useful for very lateral located lesions. So sometimes we see that in some pathologies. Last 2 weeks ago, we did an inverted papilloma on the posterior wall of the frontal sinus with also very big mucocele. And we could access the posterior wall of the frontal sinus through the superior eyelet incision better than through the draft type 3 opening. So yeah, I think you have to adapt your technique to the anatomy. I had a question for you, Christos.
Yeah.
How much gain do you get with this orbital transposition or suspension? Can you let's say, quantify it?
Yes, to be honest, my problem, I use it, but I use it less and less. Well, the problem is that you get very good access. You can go all the way really on the drill on the roof of the orbit. My problem is that you get, the orbit comes back and sometimes you get a lot of stenosis from fibrous tissue. Can I show you talking about this just yesterday? One video, one moment. That was the papilloma that I was talking about. Can I show it?
Yes, of course.
Yes, please.
I have just now, I have a nice video, just intro and just fresh from the, since it's between us, let me share the screen. There it is. So this is the video, talking of which you see. So there I am. You can see on the roof, the mucocele. You can see that. And you can see that I'm reaching there. I cannot see it very well, but you see the mid part of the, that was the papilloma, and it was blocking the frontal sinus. Now it has been removed, of course, drilled out. And you can see you get beautiful access really with a big, depends, but this was a patient with a very, look at him, he had a very wide anteroposterior and lateral distance in the orbit. You can see this. So you could go, you could access, you couldn't drill on the roof, but certainly you can clean for a mucocele when you don't have to actually drill on the roof. I think you can get there. And you keep it open so you know it will not recur. My worry always with an external incision is that if you don't have a drainage pathway, it will either create a fistula or it will recur, right? Unless you have an internal pathway as well.
Yeah, of course, we combine it with a draft type 3 or 2.
Yes,
we
exactly.
combine it. It's not the single access point. But we did, it's a very similar case. We did transorbitally through superior eyelet incision. So yeah. And it works very well, and it gives you very little scar. And I think if you compare it to an osteoplastic flap, then I think
it's much less. Yes.
It's a valid alternative, I think.
Yeah, thank you both. I think it is important to have all the sort of skills in your armamentary. You should be prepared to do endoscopic, orbital transposition, and equally conversant with the external approaches. Then you can make a right decision in managing these pathologies. So thank you, Christos. Always very interesting presentations.